Hello, Dr. Azizian. Welcome back. Today we will be discussing BMI, Body Mass Index. BMI has become somewhat of a controversial term recently. It used to be a purely medical term. However, recently a lot of people and some in non-medical circles started challenging this term, asking, is this a correct representation of somebody's weight, of somebody's appearance? So it sort of became a label that some people don't want to carry and don't want to be labeled with. And that is, of course, understandable. However, in medicine, we do need an objective characteristic of patient's health. And yes, being overweight, being obese does matter. Unfortunately, obesity is a disease, and unfortunately, we see so many other diseases coming from this disease, stemming from this disease. So yet I do agree that we need to have a more precise characterization or precise labeling, and hopefully not offensive, but just medically appropriate. So interesting article that came in Medscape Medical News by Becky McCall, and it's called, "Is Body Fat a Better Measure of Obesity in Midlife Than BMI?" So first things first, so what is a BMI? So BMI, Body Mass Index, conventionally it's measured in kilograms. It's weight in kilograms over square meters, or it could be pounds to inches, depending which metric system you used. And BMI, in terms of the sort of that threshold to obesity, BMI of 30 or more than 30 is considered obese. So one of the issues that BMI does not take into account, and that is where a lot of medical community is having problem with, is the adiposity. So adiposity is how much fat, the percentage of fat that we have in the body. And usually adiposity refers to intra-abdominal adiposity. So in this article, it's based on research by an Italian team, Dr. Luca Bussetto. I was looking for his name. So, and he states that the problem that we face is the classic cutoff with BMI, that we miss a significant group of people who are less than 30, but they still have high fat mass. So what does he mean by that? So what he means is that when we look at our body percentage, so we have fat percentage, a percentage of fat, and non-fat. And of course, that non-fat includes our bones, includes the water, and that water is both intracellular inside of the cells and extracellular outside of the cells. So we are focusing on a percentage of fat, and there are in fact widely available devices that are used to measure the percentage of fat. And the ideal percentage of fat, it fluctuates a little with age, but if we look at it, so it's a little bit higher in women, and depending again on the age, we would say that we can say in women it's 25 to 31%, and in men is 11 to 21%. So there is a little bit of course fluctuation, and it's a little bit also depends on other factors as well, but I'm just giving average numbers. So what he's saying is that we would like to see that number, the number of the percentage of fat, because some people may have better BMI number, but in reality they do have high fat percentage. And what happens is that you can miss them in terms of advocating and implementing some measures against cardiovascular disease, stroke, and diabetes, etc., because you by mistake having a lower BMI would classify them into a more favorable category, while in reality their adiposity, their fat percentage, is high. And that is a very valid point. Additionally, he discusses and proposes that we add other measurements such as waist to height ratio and also waist circumference. I have to say that in the world of functional medicine, waist circumference is used very widely. It's extremely important, and waist circumference is a very good sign into looking at the intra-abdominal adiposity. The numbers for waist circumference in women, it should be 85 centimeters, 88, 85 centimeters, 35 inches, and in men it should be no more than 102 centimeters or 40 inches. And the other measurement that he mentions and that is used in functional medicine is weight to height measurement that should be if it's more than 0.6, it is a problem, essentially. So, and I, again, completely agree with him, because I think that there is nothing wrong if a system automatically measures BMI. For example, a lot of medical softwares, they automatically measure BMI when patient comes in, patient is weight, and we get the height as well, and as we put it in the system, the EMR, the medical software, measures it and labels the patient. Yes, so that could still be there. However, everything has to be done scientifically and with a grain of salt, meaning that I think that the waist to height ratio as well as waist circumference should definitely be included in those measurements. And once you have all of this, once you have the waist circumference, waist to height ratio, and you have the fat percentage, then you can actually know where that patient belongs in their risk. So, and what Dr. Bussetto is saying, that because he says that if patients have bad fat distribution, then the risk of complication is higher than if they just only had a high BMI. So I think that this is a very good way for looking into a person as a whole human being instead of just stratifying them by BMI. And perhaps in the future there would be one parameter that would be helpful and that would just kind of give us the whole picture. I'm not sure that right now we have that one parameter. Obviously, BMI, I don't think is a correct enough parameter for that, and I'm very happy looking into this research that this confirms that. One thing about this research that I also want to add, that they had patients who had not such a high BMI. However, when they assessed their fat percentage, 71% of men and 64% of women had obesity based on their fat percentage. What does it tell you? It tells you that we need better way of classifying our patients based on their risk of obesity and obesity related diseases. So that's basically my complete agreement with this article. So I agree, and I do think that fat percentage should be measured if the clinic has the device. Again, those devices are not that difficult to get, and they are widely commercially available. They're bioimpedance devices. And additionally, just measuring waist circumference, that's very cheap. All you have to do is measure circumference of the waist. Sometimes actually in people who are big, who are obese, you have to make sure that you're measuring in the right area, and also then doing very basic calculations that you can just plug in and do the calculation based on height and weight. So all of this I think is more in tune with personalized medicine, with personalized approach, and against labeling people based on just one number. One number is never enough. So if you want to stratify people, stratify patients, nothing wrong with that, as long as they are stratified correctly and it is a useful and practical way of doing that. So very good article. So thank you so much for listening. If you enjoyed this video, please like and subscribe, and until next time, thank you. Bye bye.